This chapter is going to cover bipolar disorder and some related disorders that are closely related to there. There are at least one, I believe, YouTube videos on the slides. If you can't open the one on the voiceover that you're listening to now, open up the one that is on the printed PowerPoint that's in the same length in your Blackboard. So again, if you can't open up the one that's on this one, make sure you open up the other one because they're very, very helpful. When you look at the clinical picture of patients with bipolar, you're going to find that there are three types. There's bipolar 1, and this is a disorder where there's 1 week of mania. Then you're going to have bipolar 2 disorder. This is when they have a lower level of mania and then extreme depression. Bipolar 1 disorder is more seen in men, while bipolar 2 disorder we see more in women. Then you have this cyclothymia, and this is hypomania with mild to moderate depression. So it's a little bit lower level of the mania and a little bit lower level of the depression. You do still have the rapid cycling when it comes to bipolar. They mix back and forth, and then they're going to have the mixed episodes. So they may be having a manic episode and an episode of depression, and it's going to rapidly alternate. Almost seems like simultaneously it's going to alternate. So go ahead and look at the video that's attached to this slide, and again, if you can't see this one, go to the other source that I've printed up for you. I love this illustration because it really shows what goes on with the bipolar person. Sometimes we have been around people who were bipolar and never really realized that's what they were, or that they had this disorder because we only saw them in one of the states. When you start to see them in both states, and you get that better picture. Usually what you'll see with the manic disorders, you'll usually find that there are about 3 behaviors that they look for that are present when someone is manic. It can be extreme drive and energy. They don't sleep. They talk constantly. And it's almost like they're trying, like a politician, they're trying to get you to get on their side or vote for them. Their thoughts race all over the place. They're they're moving everywhere. They're just this flamboyant person. They get very narcissistic. They have this inflated ego about them during this time, and sometimes they can be very dangerous because they don't think things through, and so they become very they have a lot of risky activities that they do, whether it's sexually, investments with money, spending, very reckless spending, and buying things that they don't even need. The home shopping network is the worst place for them to ever go to on the TV channels. Look through this table and its characteristics of mood disorders. So you can see the characteristic, but then you can see what happens in that depressed state and what happens in the manic state. On your assessment, you're going to look at some general areas, characteristics. And so when we look at mania, we're going to be looking at the mood. And they usually go from euphoria to a quick agitated state. They give you a nice example on page 232 of an individual. You'll see a little synopsis someone wrote about an experience. They usually experience, this intense well-being. The world is good. Everything is wonderful. Everything is blown out of proportion. They laugh at the things that aren't even that funny, or they make a joke and They just start getting very, very excited, and they start talking constantly. They're overconfident, feeling like everyone loves them, and they don't know any strangers at all. And they have just so much self-confidence that it's even above and beyond. With their behavior, they may be very outrageous. They may start spending a lot, constant activities. You'll see they're being very promiscuous. They're not getting the right amount of sleep. They're not eating. And sometimes this can actually lead to physical exhaustion, which can actually lead to death or the threat of death. So in a full-blown mania, they're all over the place, and they can't stop. They may call you constantly. They're manipulative, especially with staff, when they're working with the staff, and we'll talk about that here in a little bit. They push things to the limit. They're very grandiose. They can't concentrate. They get distracted easily. Their judgment is poor, and so they're just in a wild frenzy. When we think about their thought processes and speech processes, they have the flight of ideas. They may have those clang associations where they start going in and they start rhyming, and they go off on one word, and then one word leads them on to something else or into a nursery rhyme, and they're just all over. And then they have that grandiosity, like I said. They're very inflated ego. They believe they're going to start a new business, and they're getting everyone invested in it, and we're going to be millionaires, and I've, come up with this idea, and we're going here, and we're going there, and they they wear you down. Psychologically, they just wear you down. Cognitively, in their functioning, about 1/3 of your patients who have this disorder do have impaired cognition, whereas the other group is very high functioning cognition. When you're looking at a self-assessment, your manic patient, as I said, they're very manipulative, and they may use humor, manipulation. They may start doing some power struggles. They push things to the limit. They may even try to get staff against each other. Well, this one lets me do that. How come you're not letting you do that? Or you're not letting me do this? Well, she lets me do that all the time. So they do a lot of splitting. They're very, very demanding, so you must set limits with them. It's very, very important that you have limit setting with these individuals, and you keep to those limits as well. And they can be very aggressive and very demanding, but you have to set to your limits. Also, when you look at this, staff member and staff member actions, it talks about how we do need to meet frequently, because, like I said, these patients really will wear you down, and we need to support each other and find out what it is that they're doing, how they may be trying to split the team up that's working with them, and manipulating them. Also, too, again, like I said before, make sure that you are setting those limits and be very consistent. Don't give. Because if you give a little, they're going to, give an inch, they're going to take a mile from you. Again, making sure that where you meet and their areas are very, very bland, plain walls. You don't want to go somewhere where it's a bright room with bright things, glittery, sparkly things, bright colors, because that just, when they're in a manic stage, it really sets them off and even increases their actions and their manic thoughts. Also, too, you want to give them outlets for some type of physical activity. Avoid activities that last a long time or they require a high level of concentration, because they get aggravated, but they need some way to let out a lot of activity. Letting them get outside and walking around, whatever it may be. But they need some way to let this out. As you can see through some of these guidelines, during their mania phase, it's very important that we attend to their sleep, their nutrition, their fluids. Remember that manic phase is nonstop, and so they may go days without sleeping, eating, or drinking anything. We need to also make sure we're protecting them, making sure that they're maintaining good tissue integrity, some self-control, making sure they're not attempting to hurt themselves. And we have to also remember that just because someone has a mental disorder doesn't mean that they still don't have their other issues, their history, the medical histories. So again, they may still have those other coexisting conditions that we need to make sure that we're watching over them. We need to also help them and assess with them if they're spending beyond their control, spending their money. Like I said, with that poor impulse, they may harm themselves or others. We also need to protect them from inhibited behaviors such as promiscuous sexual activities, the spending, bankruptcies. We also need to make sure that we try to make sure that we get them into a stable state. That's going to be our main control. The other thing is looking at, again, their medical conditions. Do they have any other conditions, or are they, also a substance abuser as well? So we need to make sure that we're looking into their whole history. And then also, too, we want to, touch base with their family's knowledge about their condition, their medications. Are they taking their medications? Sometimes they don't like the way the medications make them feel, and so they stop taking. So how can we help the family to help this patient, making sure that they are doing what they need to do to hopefully get into a maintenance phase? As you see here, there's the nursing diagnoses, and there's different ones that you can see. Here's a few here that you would see with someone in the manic phase, but also defensive coping. We can use self-care deficit. Remember when they're in that manic phase, they're not eating, drinking, maybe dressing appropriately. If they're depressed, they may not be dressing appropriately or bathing and so forth. Sleep deprivation, impaired social interaction, wandering, and so forth. So again, we have a lot of different nursing diagnoses that we can use to treat with these symptoms that they're having. And they have a really good table on page 235 that talks about the diagnosis and the outcomes and what are the signs and symptoms that you would see. As far as outcomes identification, there's 3 phases. In the acute phase, you want to prevent injury. You want to protect them. You want to make sure that they are eating and drinking, that they're under some type of control, and their thoughts are under control, and they're not attempting to hurt themselves or someone else, that they are getting some sleep and rest, and we monitor their vitals and so forth. In the continuation phase, this can last 4 to 9 months, and we are hoping to prevent them from relapsing during this time, and so we want to make sure that they're starting to gather, and as well as their family, an idea about their condition and the process, making sure they know about their medications and how important it is, and not to be taking any other drugs along with their medications, and what are some signs and symptoms if they're going to start to relapse, so hopefully we can catch it in an early stage before they become full-blown again. Also, making sure they go to support groups and therapies, making sure that they're using good communication skills, and problem-solving skills, and helping them to acknowledge, what are good decisions versus the bad decisions. In the maintenance phase, again, this is when we want to prevent a relapse. Again, you want to continue that and limit the severity or duration of any future episodes. So again, learning those interpersonal skills, strategies related to work, family, whatever may set them off, and also maintaining their groups and support groups and any kind of therapy modalities that they've been using. When we think about their planning under the acute phase, you want to think about medical stabilization. You want to maintain that safety and help them with those self-care needs. When they're in the continuation phase in our planning, we want to think about maintaining medication adherence, psychoeducational teaching, and any referrals. During that maintenance phase, again, our plan and for them is to prevent a relapse. In the process, we get to implementation, and many of them are very ambivalent about treatments. They don't think they need any help or any treatment at all. And sometimes they'll wait within a year or so before, and sometimes even 6 years is the average when some of them will actually get help. And one of the things that we need to do is that we need to get them onto a mood stabilizing medication. And unfortunately what happens is a lot of them don't adhere to the regimen that they're supposed to stay on. In your textbook they even have a case study that I think would be very helpful about a patient who's in the manic phase, and it starts on page 236 when you're reviewing. Some of the interventions that we want to think about is making sure that they are, in an area of good communication. We're thinking about the environment. You want to think about safety, and then the basics: sleep, hygiene, and elimination. So when we're thinking about some of the implications, those are the things that you want to look at, especially for the depressive moods and the manic phases. One of the things we know about elimination is that most of them end up being constipated. So again, we want to address elimination issues, for example. Again, during the acute phase, they're very, if they're depressed, it's very intense time. They may be required to come into the hospital and stay in the hospital. We may be giving them lithium, because that is the first line of treatment for persons with bipolar. They do not recommend antidepressants because of the central nervous system may become overactive, and then the antidepressants may actually cause a hypomania or mania state. So these patients, when they're experiencing depression while taking maintenance levels of meds, may benefit from increased doses of just their original medications. When depressive episodes start to have some of those psychotic features, they may require that they take a second-generation antipsychotic medication along with their other medications. During the continuation phase, again, it's crucial that families and the patients prevent a relapse. And so, again, making sure that they are adhering to the treatment regimens and therapies that they're supposed to be going to. When you think about the acute phase for the manic, again, it's stabilizing their medications, making sure the exterior controls such as the safety and the environment and setting the limits, making sure that we speak with them in a neutral manner and that we're non-threatening and provide those safe boundaries for them, and then again taking their medications that they need. And the same holds true in the continuation phase for the manic patient as well as the depressive patients. In the maintenance phase, again, we just want to prevent that recurrence. So again, we're making sure that we have the resources available to them and support groups, self-help groups for the family, mutual supports, and any other community resources that are available to them. As I've said before, in communication, we need to make the time to be with the patient, but again, make sure that we limit the time and the limited setting and consistent and with our patient about those limits. That's going to be extremely important. The other things that we need to do is make observations rather than asking direct questions, because this may cause them to have some anxieties. They may have a little bit lower response time, maybe because of medications, especially if they're depressed. Maybe take them a little bit longer to respond. Give directions in very simple, concrete sentences. We also need to give the client time to respond when holding a conversation. Also, again, as it says here, the clients in a manic phase are unable to concentrate or sit still for more than a few minutes during a conversation. You may see a lot of those flight of ideas with these patients. Again, stay very neutral. And then again, make sure that you're having frequent staff members to plan consistent approaches with them when you are meeting with them. And it's very important to utilize those good therapeutic communication skills with them. As I said earlier, lithium is the drug of choice for patients, and they may be on this lifelong. Again, remember, they have therapeutic levels that are very, very close. You can see the therapeutic blood level, what that is, and the maintenance level. And then look at the levels of toxicity. It's very, very close. So they're going to have to be watched very closely, coming in for those appointments. And then we, hopefully keeping them on a maintenance level, but we've got to get those lab works and making sure that they are coming in and being compliant. It's very important that they stay on this medication and take their meds to prevent a relapse or limit the severity of an episode if it does occur. Again, we do want them to try to stay in this maintenance phase. Again, review the information provided for the therapeutic and toxic levels. There are two major risks when taking lithium lifelong, which is hypothyroidism, and sometimes the kidneys are unable to concentrate the urine. So we have to be very careful when they are taking the lithium. Lithium can inhibit about 80% of the acute manic and hypomanic episodes within about 10 to 21 days of taking the medication, so up to 2 to 3 weeks. It's less effective if people have a lot of the mixed mania, which is that rapid recycling. Again, we need to make sure that they are taking their medications and staying within that therapeutic level. Again, we have to remember that it is not a cure, but it's a good maintenance. They still need their therapies. Someone talked about their therapies and taking their medication, and this was Patty Duke. And so that has a nice little excerpt in your book on page 240 about how she felt about taking her medications. Again, those therapeutic levels, we have to be very careful. We want to look out for signs of lithium toxicity, which can actually lead to death. So again, we really want to make sure that we're keeping a close eye on these patients. Hopefully we can get them stabilized. It's also very important, especially for our older patients, that we start low and go slow, making sure that we make that they are not over medicated too soon. They do talk about some of the side effects and signs of lithium toxicity, so I'm not going to repeat that. This is on page 240, table 13.3 in your textbook. And I think it's important to read about the patient and family teaching about lithium therapy on page 241 as well. Also, anticonvulsants can be given to help to treat some of the mood disorders, and they're listed here. Again, anticonvulsant drugs can help with the cycling, that rapid cycling that's the patients are having. And so we have to look at other options because not everyone can take the lithium, so we may have to give another drug or something along with the lithium as well when we're treating these patients. So again, you want to look at anticonvulsants, and these are the ones that are the most recommended for bipolar patients. Remember, during depressive modes, antidepressants are not recommended because this could lead to a hypomanic or manic states. We do have anti-anxiety drugs, though, that can be given, and they're listed here. And again, they're very useful in the treatment of acute mania. especially those who might resist any other types of treatments. They're effective, and especially in managing the psychomotor agitation that we see a lot in our manic patients. However, you do want to avoid them in patients with a history of substance abuse. With bipolar, the staff needs support because these patients, as I said, are very taxing. They're very manipulative. Staff meetings are very important to support. Teamwork and safety is really key when you have patients dealing with bipolar disorders. There's a nice box on page 245. It's called Patient and Family Teaching about Bipolar Disorder, and I think that's very, very helpful. They still do ECT therapy. It's not like what you see on TV and in the movies, but it helps to calm or subdue a patient who's in a severe manic mode. And it also helps to treat those who might be resistant to other treatments, who have that rapid cycling of mania. So again, ECT is effective for those patients with the rapid cycling. Also for those who might have paranoid destructive features, they might not respond effectively with Librium therapy, so they may have to do the ECT, and especially those patients who might be suicidal. Again, teamwork is very important. Working together, good documentation. Sometimes we have to put them in seclusion just to get them to calm down, because they become sometimes out of control, and especially in a facility where you have a lot of patients wandering around in a day room, they may set other patients off. Some other types of therapies too that you might see is the psychotherapy, which is your cognitive behavioral therapy, and it works well with the in relation to or along with your medications. So that's all I have for now. Please make sure to review, and then we will go from there.